we really do want to make sure that this is a helpful webinar for you, so please add any questions you might have in the chat, and Lauren can manage the questions as she moves through the webinar. And I think we're not going to spend a whole lot of time on the front end with introductions, but instead of that, I would love it if everybody could put in the chat their name and their organization, just so we know who's here. So if you could take a minute to do that, that would be really helpful. And Laura, you can take it from here. Thank you.
Thanks so much, Aubrey. So as Aubrey said, we do have members of the RT Welter team that will be monitoring the chat while I speak. So please feel free to ask questions in there, utilize that as well. Especially if you have questions as I go through, they'll be able to answer those as we go along. Prior to today's webinar, we did request that each of you come with a report from your individual clinics with your production. We will be using this later on in the presentation for some kind of reflective material so that you can really see where your clinics are at with some stuff. So make sure that you have that. If not, no big deal, but it will help out. There will be quite a bit of referencing to that right about the middle of the webinar. Also today, you should have received our RT Welter diagnosis coding booklet. This is just a really great reference tool. You can share it with other members of your staff, your clinics, and this is really just kind of one of those tools that we hand out to some of our clients that allow them to better code for their diagnosis coding. It's one of those areas that we see a lot of issues with. So keep that in mind, have that close by for you. Okay, so as you can see, we have a pretty full schedule today. So not everything we're going to spend a lot of time on. There will be some stuff that we're just going to quickly breeze through. And there's going to be other times where we will spend a little bit longer on certain topics. So again, feel free to use that chat, ask questions as we go through. And yeah, let us know how we can help you as we continue on. Really, the objective of this session is to identify opportunities for revenue, increased revenue rather, and for an overall school-based health care sustainability. We want to make sure that you stay in business and you stay around. You are very important to communities. Our hopes for this session will be that it's highly interactive. Again, use that chat. There will be times where we're going to open up the floor for a little bit more of interactive discussions. So really make sure that we're utilizing that. And we really want to focus on some main objectives of this is that, one, you learn how to monitor some of these areas of billing leakage that you might be experiencing. We'd also like to identify areas to increase revenue, right? So we're not just going to talk about areas where you may be falling short, but we also want to talk about areas that you can gain a little bit of extra ground there. Understand how to prioritize billing leakage areas of concern and share best practices for addressing common billing leakage areas across all of the clinics. You know, you might not be the only one who's having these issues. Also, we will be conducting a refresher course closer to the beginning of school, where we'll be going a little bit deeper into some of these things, answering some more questions that you may have after this training. So definitely keep that on the calendar so that you're aware. We would love to see you all back in maybe August or September. Prior to today, you should have received a pre and post webinar training survey. There are questions that are specific to before as well as after. This is really helpful to myself as a trainer to see how we did answering your questions, and also to make sure that we are continuing to grow as well. We're here to help you improve, help you be better. So we would really like for that in return. We also have with those before questions, we really would like you to answer those as honestly as possible. If you don't know, or if you feel really comfortable in some of these areas, feel free to say so. This is completely anonymous. Nobody's going to come back and say, how could you not have known that beforehand or anything like that. So really be as honest as possible. It really does help us out. So as part of the interaction of this webinar, we will be doing polling throughout, and we ask that everybody does interact with these polls. And so the first poll that I'd like to get started is to see how many of you, if any of you, submitted a question prior to today's webinar. So if you could go ahead and maybe just vote for us, we'll give that a few seconds for everybody to vote. Okay, looks like everybody that was going to vote has. So it looks like we've got a pretty good mix here. The majority of you did say that you didn't answer any questions prior to today, which is just fine. But if you do have questions, we again really want to stress that if you have questions, please feel free to ask them. Use that chat feature, or if questions come up throughout, and add it to those post-survey surveys, because we'll definitely address those in the upcoming webinar, as well as we're happy to address questions on a one-on-one basis if you have something specific. So to start off today, we really just want to talk about coding essentials. Everyone knows that clinicians and coders kind of speak two different languages at times, even though we're talking about the same things. So this is just a really good reminder that coding is, it's there, it's part of our lives and part of your clinics. However, we really want to make sure that you're aware of some of the things that can really cause some of these roadblocks or leakage areas of leakage. And so really the first bullet point on here is really important, especially when you're talking Fqhcs, and even some of you that are not Fqhcs. Document what you do, code what you document, regardless of reimbursement. This is so important, and we'll get into it a little bit more as we kind of move on. But there's so many different reasons why this is important. If you look at the Colorado SBHC billing manual, this concept is actually addressed in regards to SBHC as well as Fqhc reimbursement, as well as this is really important when we're talking contract negotiations with our various payers. Another really important bullet point here is number 4. The existence of a code doesn't guarantee reimbursement. I'm sure all of you are looking at that one and know for sure that there are plenty of codes that you don't get reimbursement for. And you might be looking at it wondering why one of your coworkers or a friend at another clinic is getting reimbursed for a code. And again, we'll go into those reasons here momentarily. But that's something that is very important as well. As number 6, looking forward, diagnosis, coding, and clinical outcomes will and are driving reimbursement outcomes, right? So as we see risk adjustment and as we see more payers going to these models where providers and clinics are being reimbursed based on their patient populations and how sick they are, this is really going to come into play a lot when we start talking about the overall big picture of reimbursement and at the end of the day, you know, we want to keep doors open. And if we are not getting that money coming in, it's hard to keep those doors open. Okay, defining documentation. So this one is really, again, these first few slides are just going to kind of be informative, making sure we're all on the same page, right? So clinicians are meant to be storytellers, not coders. If the documentation is completed with this in mind, the codes will follow. And it's so hard because so many times clinicians are trying to be coders, and we're, as coders, trying to tell clinicians, stop, don't worry about the bean counting, don't worry about all of these little things. Tell me a good story. If you tell me a good story, then the coding will match what happens, right? And then that kind of goes into our golden rule of coders, which is document what you do, code what is documented. If it isn't documented, it didn't happen. So many times we meet with clinicians and we show them a note that, you know, appears to be underdocumented, and we sit down with them and they can look at it for a split second and say, oh, I remember this encounter. And then they will go through and they will tell me a huge story. And, you know, the first thing we say is, wow, that's really impressive that you remember all that, but it's not in your documentation. And that's very, very important, because not always are you going to have the opportunity to talk to another clinician when they're assessing that patient and seeing what happened, you know, further down the road, 5, 6, maybe even 2 years ago, right? You never know. So you always want to make sure that we're documenting everything. And that just really comes back, you know, we talk about the full flow of things, right? You tell me a good story, it's going to show that there was adequate patient care, and then that's going to follow in with your reimbursement, appropriate reimbursement, I should say. Defining coding. This is really just, again, kind of a nice little refresher. We have 3 different codes that we deal with. For the most part, we talk about CPT and Hcc codes. These are our procedure codes. This is how the majority of claims are reimbursed, is based on these procedures, right? We're talking fee for service. You're being paid for what you're doing. And then we talk about Icd-10 and these are our diagnosis codes. These codes tell us what is wrong with the patient. Why was this procedure necessary? It gives us that medical necessity. So really, when we talk about coding from essentially 1 or 2 codes, we should be able to know what's going on with that patient, or why that patient needed to have that procedure or come in for that visit. Okay, everyone's favorite, EMRs. They have changed the way that the healthcare system works. And the one really big takeaway that I can tell you about this is, don't let your EMR and your templates dictate what you document for that patient. So many times we read notes and we can go from one patient to another where they're almost identical. You can't tell any type of clinical difference between the two because it's all templated. So you really want to make sure that you're using a good mix of templated statements. Those are wonderful. They save you time as a clinician, so you can really focus on that patient care, but also that free text, so we know what is going on with this patient, what's happening with them currently today. This is just a really good slide to show you there are so many different references that we can go to. There are thousands, hundreds. It's incredible how many different places we can go that will give us the information we're looking for. And so it's really important here that we know where to look, right? So many times you have a question, and if you try and Google it, or you try and ask a colleague, you know, they might have 4 or 5 different references that maybe you've never heard of before. So just kind of giving you a little bit of a glimpse into what some of the references are that we use on a daily basis. We're going to do another poll here, And this one here is just asking, how many of you use or have used the Colorado Fqhc or Health First website, any of the Colorado Department of Healthcare policy, any of those? Okay, that's actually really great. It looks like most of you use it as your main reference, which is really great. It is so knowledgeable, and it's really going to be your first line of questioning. You know, you're looking specifically at Colorado-based clinics, so going there first for information is always going to be your best reference, right? And it's going to be the most up to date. Sometimes you go to some other websites and it's going to take a little bit of a lag time because they're going to need to update based off of what Colorado State actually sends out. It looks like about 47% use it as the main reference, with about 33% using it seldomly. So that's really, really great, everybody. Okay, so really quickly, just kind of going over what are some of the different services that we're going to talk about today. Again, the Colorado Association of School-Based Healthcare does not provide these services. They are your advocacy organization, right? They're the ones that you can go to when you're having problems with a bill or you're not understanding why some things are happening. You want help with legislation being passed. These are the people that you're going to want to go to. They are so knowledgeable. These are all the things that they cover, right? And it's everything that you as a clinic, as a provider, as an administrator for a clinic, these are things that you're doing day in and day out for your patients. And so knowing that they're here as a really great source is definitely important because they're local. They're the ones that kind of boots on the ground. They're the ones that can help you get things done. Okay, we're gonna first look at some reports. This is a report that I received from one of the school-based health clinics in Colorado. And we're just gonna kind of break down reporting and why it's important and what information we're really looking for when we look at these production reports. So this first slide is going to show us our office visits. And you see here that they actually have in their EMR, their codes are set up into procedure groups. And that's really great for filtering. You can see what's happening. It's just kind of giving each code a happy home, right? Where we can group them all together. And then we're looking at our code descriptions, and then the units. This report that was ran was for the 2019-2020 school year, which was about August 1st till middle of May. And this is going to show us all of the times that they reported a certain code. So if we're looking at this report, our most reported office visit code is going to be a 99213, which is going to be a low complexity illness visit. So somebody's coming in, maybe has a sprained ankle, or somebody's coming in with an ear infection. And they've reported this 429 times throughout that reporting data, or that time set. We can also see that they've reported the 99213 59 additional times with their modifier 25 amended to it. So that's going to give us a little bit more information, right? Maybe it was reported in addition to a wellness visit, or maybe it was reported in addition to some other type of procedure. So we're gonna just kind of explain these things as we go through. The one really interesting thing that I see with this is that overall, they really only had 941 office visits. And, you know, not knowing anything about this clinic, are they a small clinic? Are they a medium-sized clinic? How often are they seeing patients? We can start to think of some of these questions. How many clinicians are seeing all of these patients? Is this one clinician's productivity, or is this stretched out between 5, 6, 10 clinicians? So we really start to kind of think about all of these things. This next slide kind of breaks it down a little bit more. So now we're not just looking at office visits and those 992 series codes. Now we're actually looking at the preventive, codes as well on the chart to the left. And we see that the preventive visit code 99394 is just below their top 5 most reported codes here with 53. But most of it does, again, we're still seeing that the majority of their office visits, or their visits in general, are those office visits. And we're really in the established patient, but we do have a significant amount of new patient visits at that 99203 level. So again, we're kind of starting this critical thinking. We're wondering, what's their day-to-day like? What type of patients are they seeing? Why are they coming in? How many clinicians are seeing all of these patients? We're starting to kind of have that thought process, right? And then if we look at the graph on the left, or on the right, is that now all of a sudden we see that the most reported code at 429 has jumped up to 3,514 for this J1050 FP code, which is of course our depot shot. And now we're still critically thinking, and we're wondering, well, there's a few different reasons why we might see such a large increase in the amount of times that this code was reported. First off, being that with a depot shot, you should be reporting 150 units of that every time you are administering one of these shots, because if you look at this code, it's only for 1 milligram, right? Where your dosages are 150. So that's a really big area where we have seen in past reviews with clinics is that they're losing a ton of money because they're thinking, hey, we gave 1 shot, we put it in as a 1, and then we send it off, and they're maybe only getting cents on a dollar comparatively to what that shot actually costed. So start thinking about that. Hey, are my billers doing that? Is that something that we do? These are all things that reports can tell us, right? Where if you see on your reports that maybe your depot shots aren't as high, well, 1, maybe you don't have as many patients who are coming in for that, or possibly you might be having an issue with the billing, right? Where it's not triggering that increase in units. We also start looking at things like under the unassigned code, which is a newcomer. What's that for? Is that one of their tracking? It's a dummy code, right? That they're using maybe for tracking. What's that doing for them? Why are they having that? Why are they using that? Do we use that in our clinic? What type of tracking are we using for the various procedural and payer required tracking codes, enabling services? We start to think all these things, right? The other thing that I look at is right there, if you look down a little farther, it says tracking codes, and they use an SCCC with a modifier 4 is the way that I would read that. And again, that's your tracking codes. Those are things that you can use to make sure that you're hitting these certain reporting data points that we need when it comes time to start contract negotiation with our various payers. Okay, so here's going to be our first kind of interactive, take a moment to actually look at your reports. And here's an opportunity for you to really use that chat feature see what, take a moment, critically think about your reports. What are you seeing? Is there something that you're doing consistently? This is something that we do probably 5, 10, 15, 30 times a day, and it's not in my top 5, reported codes. What's happening there? So is there anything that you just don't even see on your report, right? So it's something that maybe you're not getting reimbursed for, so nobody actually puts it onto that UB40 or billing form. Are you tracking all the services you provide? With your FQHCs, what's happening with your single rate reimbursement? Are things not being reported because it's all kind of bundled? It's a bad word, I shouldn't say bundled, but it's all considered part of that FQHC service. And then it's just important to remember staying updated with ongoing coding and billing updates. They change every year, sometimes every quarter, sometimes during a PHE like we're in now. So it's really important that we're paying attention to that. How many times has your clinic had somebody come in for a COVID screening or testing? Have you seen any of that? Are you seeing that reflected on your reports? So let's take a minute. Feel free to unmute yourself if you'd like to ask a question, or definitely use that chat feature. We are monitoring that as well. Everybody's quiet. I'm not seeing any questions. Oh, maybe anybody? Questions? What are you seeing on your reports? All right, so the chat's kind of quiet at the moment, so I was planning to have a little bit more time. Obviously, this was a presentation we wanted to have in person with everybody, so at this point, we would have kind of broken up into groups, reviewed reports together, kind of saw what everybody else, what's going on there. So we'll move on, but again, feel free to use the chat if you do have questions. Again, Ginger is monitoring and having everything, so as questions come in, please feel free to ask there. Okay, now let's talk about common revenue leakage areas, okay? So when we talk about areas within the revenue cycle that we can possibly gain a little bit of traction, right? Kind of make sure that we're keeping our doors open. Really the first thing that we all see is that we have inaccurate levels of service when we are reporting our E&M services, our E&M visits. This is happening all over. It's not just at school-based health clinics. It's not just pediatrics, it's everywhere. And E&M is such a big part of our day-to-day that we really want to make sure that our coding is as accurate as possible. The other big thing that we see is time-based reporting and some issues there. We'll talk about those two things in a few minutes, but also kind of looking over to the right side, your asthma ACTs, right? Your ages and stages questionnaires, your Edinburgh screenings, which I'm not sure how many clinics are on that actually even have that going on. But these are all really important when we talk about areas of revenue improvement. The next few slides, we're going to talk about, this is a pediatric clinic, and this was, as you can see, some of their records from the second part of 2018. So really, again, we're going to use those same reports, those same production reports. And we're going to keep kind of using that critical thinking, right? If we look at this, overall, their production between new and established patients, that bell curve is really similar, right? We do have a few more of the 99214s than we have of the 99204s. So we are seeing a little bit more of a complex established patient as opposed to a new patient, but really not by that much, because really that 99202 is a lot higher than the 99212. But our 213s and our 203s are really they're really, really close. And so overall, what we see here is that it's pretty even, right? They're new to established patient, and we're thinking, okay, does that feel right? The patients that we see, the patients that we know are coming in, does that feel correct when we're comparing it to what we know is coming in through the door? This is an individual production comparison between 4 of the providers within that same clinic. So again, we saw what their collective coding pattern looked like, but now when we break that down, we see these 4 different providers, and it's all over the place, right? If we're comparing provider A with provider D, again, we're going to keep this critical thinking going. Why is provider A seeing so many 212s and 213s compared to like providers C and D who have that higher level of 99214s? Well, these could be many different things, right? Maybe provider A is a new clinician, fresh out of residency, and they're just starting to get their feet wet, and so they're seeing a lot of those follow-up visits. Or it's a nurse practitioner, and so she's seeing a lot of those follow-up visits or those low complexity illness visits, compared to provider D, who might be a partner and he's been doing this for 15 years and he's in the mix of it and he's seeing all of these very complex cases. These are all examples of why your overall coding pattern might not be exactly what every provider should be reporting as well. So again, we have to use that critical thinking and how that works within our own clinics. So as we're talk about leakage, areas of leakage, and we talk about E&M coding accuracy for this same clinic, now we can see that for this particular audit, we reviewed 329 records, and overall the clinic is doing quite well. Even with their bell curve and with where all of their different clinicians are at, they're still at an 85% accuracy rate for their E&M coding. But the one really big thing here is that they are having a 5% overcoded and an 8%, pardon me, a 5% undercoded and an 8% overcoded accuracy rate. Now this is from a few different things, right? That undercoding, they're undervaluing their time or their knowledge, right? So they're not coding up to the correct level. They might be reporting those 212s when really they should be reporting a 213, or they're turning a 213 that should be a 214. The other thing with overcoding is sometimes it's not even that it's overcoded, it's that it's underdocumented. And that's something that's, again, really important when we talk about those EMRs and our templates and how they can really be a big area of part of our problems, right? Is that clinicians are leaning a little too heavy on their templates and we're sometimes missing all of these other things. And so, they're missing that opportunity to get the 214 because that information wasn't included, so we had to drop them back down to, let's say, a 213. Really quickly, and you can just answer in the chat, we don't have a poll for this, but I'm just curious if any of you have ever conducted any type of an internal, a peer-to-peer review, external review, anything like that, because these can be really eye-opening to some areas within your organization itself of where you might be able to find some of these areas for improvement with our documentation, but also with our E&M coding. Okay, so let's start talking about E&M coding and what are the different ways that we can code for these encounters. So when we talk about E&M coding, we're gonna just spend a few minutes on this. We won't harp on it for too long, but we will kind of get a little bit into the nitty-gritty on this. We have two different ways that we can report these. We have time and we have our key components. And so with all of these, we talk about documentation of medical necessity, we talk about history exam, medical decision-making, and then that counseling time, that 50% of our face-to-face encounter being dominated by that counseling and or coordination of care. This snippet here is taken from our RT Welter coding calculator. And this is something that we give out to our clients as a way for their clinicians, their staff, to kind of quickly get to what code they need. We're going to go a little bit deeper into this in August when we do our kind of refresher with all of this information, and we'll talk a little bit more about how to use this tool. We'll do a handout of the PDF version of this so you can actually see everything together, and it'll kind of give you a little bit more of an insight on that. Before we start talking about anything too intense, I want to do a quick poll, and this one is just kind of a fun knowledge for us as trainers. Who is aware of, has participated in any trainings regarding the 2021 E&M changes that are coming up January 1st? Okay, wow, that's really interesting, everybody. So it looks like about 40% of you have no idea what I'm talking about. So this is really great that you're all here. Again, we're not going to do too much deep dive into the 2021 changes. We will mention some things as I kind of go through the next few slides. This again is going to be something we'll address more in depth in August, because these changes will come into effect January 1st of 2021. Okay, so when we talk about E&M coding, we talk about key components. Our first key component is our history. And so we really want to talk about what's important here. History of your presenting problem, what's going on with the patient today? How are they here? Why are they here, right? So we want to talk about their chief complaint. A lot of times we see just follow-up written in their chief complaint. Well, what are they here following up for? And that's really where your storytelling as clinicians comes into play, because we want to make sure you're telling us a good story. Are they here because they fell and now their arm hurts? Are they here because they've got the stomach thing going on? What's going on with the patient today? Under documentation, again, of this HPI can lead to overcoding all the time, because clinicians are just documenting a few notes, or maybe it's just being put in as a follow-up from last visit. And so really that's bringing them down, because especially when we're talking about new patients, all three of our key components must be met or exceeded to get to that level. We also want to talk about inconsistencies between our HPI, our history of present illness, and our review of systems. Review of systems is there as an inventory, right? It's here to tell us what's going on with the patient today. Do they have a headache? Do they have, you know, a hurt wrist? Is that where they're hurting at? This just kind of gives us a little bit more information about everything that the patient is going through or is presenting with today. And the past family and social history is really there to know, is this something that's a bigger concern, right? When we're talking about let's say a pediatric patient who's coming in and maybe has anxiety and, you know, they're really struggling. Well, if we're looking at their family history and all of a sudden we see that it's something that maybe their mom has, now we know that maybe we need to elevate this a little bit more and it's not just, you know, they're having a hard day, it's maybe something a little bit more. So that's really there that helps us tell that full story of what's going on with the patient at today's encounter. Our second key component is our examination. And so medical necessity or pertinent exams are huge here. Don't leave out musculoskeletal if a patient has leg pain. But also, is a musculoskeletal exam really necessary if a patient's coming in for a chronic ear infection? You know, things can be taken both ways. The patient's here, we might as well check it. It doesn't take that much longer. But also sometimes with exams, we see a very checkbox or templated exam where you're going through and you're maybe just checking a box off that it was reviewed and everything is normal. Well, what's that again? What's that telling us about today? How is that helping us get a better picture of everything that's going on with that patient? And then finally is medical decision making. This is our third key component, and really this is the bread and butter, right? This is what is going to be our most valuable, because this is what's telling us what you as clinicians feel is happening today. This is you deciding, this is your, this is all those years of school coming into play, right? This is you telling us, these are the number of diagnoses that I looked at today. This is the complexity of what we're doing today from a plan standpoint. I'm ordering labs to rule out something that I suspect it might be. I'm talking to other providers about this case. I'm requesting old records from their past clinician or from a past fall because now this old injury is acting up. We're looking at all of those data points. And then that overall risk. What are we really doing today? Is the patient here for a chronic ear infection? Something I'm familiar with. The patient gets these about once a year, right about allergy season every year. Simple antibiotics and some rest will help it. Or are we looking at something that's brand new and we're really not sure what's going on? This is an undiagnosed new problem. That's going to elevate our concern or our risk. So this is something that's really important. And moving forward with our 2021 guideline changes, this is really, you know, we're going to remove that history and that exam from being as important with your documentation. And now all of a sudden, MDM is going to kind of take center stage. What's going on? What are you as a clinician going to do to help out? Or how are we going to plan treatment for this illness or injury? So this is just another great little take home. We always like to look at it and say, you know, what are my 3 take homes, right? So clearly identify the problems, right? Clinical impressions are huge. Are they acute or chronic? And making sure that we're not under documenting. Make sure that the clinically relevant details are there, right? We want to know all of these things. This is what we're looking for. Okay, time-based coding. And again, you see, this is in 2020. So again, things are going to change, but they're not going to change right away. We're still going to have a few months of school where you're going to be still in this 2020 ruling. So we want to make sure that we're really focused on this. And really, with time-based coding, we have 3 requirements. We need to know the total encounter time. We need to know that greater than 50% of that encounter time was spent in counseling and or coordination of care. And we need to know what you talked about during that code or during that counseling and coordination of care, right? You can't just say, yep, talk to the patient for 15 minutes. Well, what did you talk to them about? What's going on? Again, this is your storytelling. This is you being a good storyteller. Tell us, you don't have to go into detail, but you know, especially with pediatrics, sometimes it can be a little, we want to be sure that we're following HIPAA, and you know, you don't need to go too greatly into detail. However, we do need to know that we talked about certain concerns that that patient may have had, or even the patient, or pardon me, the parent of the patient. When we talk pediatrics, so many times a parent will come in with their child, and all of a sudden this is a new patient, right? And so, or this is a new mom, and so she's got a little one and she has a million questions that she wants to ask, and you're answering them, but that's time, and that matters because your time is valuable. And so we want to make sure that you are using this because it is there. Really briefly, to talk about our changes in 2021, right now, our coding descriptions list average times. And so one of the really great things coming up in 2021 is that now our codes are going to have a time range. So right now, using 99213 as an example, we look at it and it's an average time of 15 minutes. Well, you're not going to sit there and be like waiting for 15 minutes, you know, answering questions, talking a little slower, right, to get to that 15-minute time threshold. And you know what, you just don't want to be looking at your watch or the clock the whole time you're there anyways. But now we're going in 2021 and we're going to get a range. So instead of an average of 15 minutes, now 99213 is going to be 20 to 29 minutes. So now you have this range to hit instead of trying to always hit these exact times. And so from a policy standpoint, this is going to be super helpful for you administrators who are on today, for you to be able to make some of these policy changes for various specialties within your clinic to be able to have this. So it's something really, it's something really great. Here's a scenario for everybody. This is, again, from that same pediatric clinic that we referenced earlier. This is a great example of a time-based encounter. The patient comes in, counseling and coordination of care discussed. The patient's on Ritalin, we're gonna stop that. We're gonna try this different medication. Mom is involved. She's going to be vigilant as to what things are happening. As far as it looks like the patient might have a facial tic going on, so, and maybe it has something to do with that medication. And so at the bottom here, you see total time spent 30 minutes, time spent in counseling and coordination of care 28 minutes, and then more than 50% of time spent in counseling and coordination of care, yes. That's the way that this clinic has set up their time-based reporting templates to work. And this is really wonderful because it does kind of break it down. This is a little bit more than what you even need to do. A simple statement that, you know, total encounter time was 30 minutes. Greater than 50% of that time was spent in counseling and coordination of care. We discussed X, Y, and Z, or even more than 50% of time spent in counseling and coordination of care, C, A, and P for details, right? Where you don't necessarily have to spell it out twice. It's already there. We can see it there, but you just want to make sure that it is there somewhere so we know what those conversations entailed. Again, you don't have to go into super great detail unless you want to. Okay, so well-child immunization, preventive medicine. This is such a huge deal, right? So many times, especially again with our pediatric patients, kiddo comes in for a wellness exam and the parent or the guardian is with them, and all of a sudden they start wanting to talk about X, Y, and Z that happened maybe 3 months ago, or, you know, they woke up this morning with this cough. And it's really hard as clinicians sometimes for you all to kind of separate that. And so we really want to make sure that, again, your time is being accounted for, but also that if for some reason a wellness and an illness has to be, you know, reported on the same day, that you are being reimbursed for that as well. Some kind of big takeaways here. Periodic comprehensive preventive medicine services. These are typically well patient exams for newer established patients. They're for evaluation or reevaluation of overall health conditions. And the code selection is dependent on the patient's age. Along with that code selection is age relevant screening. So we're not going to do a developmental screening on somebody who's, you know, maybe 24, because they're already kind of past that developmental stage. However, developmental screening for some patients or for some age ranges is going to be part of your overall wellness, unless there's maybe we see a lag in a developmental, in one of those developmental screenings, and we'll talk about that in a minute. Immunization. Big thing with immunization coding is we want to make sure that we're coding it correctly. So immunizations include 3 big things, right? Was counseling also performed prior to this immunization? Are we coding for any additional immunizations? So are they getting more than one? So we want to make sure that we're getting those administration codes, or those the immunization administration for those additional immunizations. And then we also want to make sure, and this happens so often sometimes, is that we forget to actually report for the product. Make sure that we're using those direct codes and actually charging for the use of that product. So really those 3 big takeaways with immunization. And then preventative visits, preventative medicine, or pardon me, preventative medicine codes, the 99401 to the 99404. These are for counseling and risk factor reduction. These are really big for especially some of these school-based health clinics, where we're really kind of starting to talk about that change intervention, providing that separate encounter for those conversations, for that counseling, to help promote that healthy lifestyle that we want to get kids into. The earlier the better, right? Research has shown us that. And finally, we can't forget about our Fqhcs out there. Your revenue codes are going to be huge here, making sure that we're using our 529 for our physical health and our 900 for our behavioral health, right? So making sure that we're using that on our line items. Here's a great little take home for everybody. Wellness and illness on the same date, and really what that entails. Because again, so many times we have a patient come in for their annual wellness and all of a sudden it turns into this huge thing, or, you know, we notice that there's something else going on with this patient today. So what's needed from a documentation standpoint? We want to make sure that it's significant enough to require additional work for the key components, right? And really making sure that we're documenting that. You know, as you could see from that last bullet point, if it's worth an extra code, it's worth an extra paragraph. It doesn't necessarily need to be broken off into 2 different pieces of documentation. However, there are some clinics that have internal policies that do require that. So if that's something that you as a clinic have, making sure that everybody's aware of that and that that is an internal policy, but knowing that it's not required. As long as we can look at that one documentation and see that significantly separately identifiable part of that illness visit, we can move forward and that code will be supported. And also with the abnormal findings, our Z codes there, and we'll get into Z codes here in a little bit. Okay, some other really big part of billing is our Ncci Edits and our MUEs. These are put out by CMS, and so we've got our Centers for Medicare and Medicaid. And what do these edits mean? What does that mean? If I'm getting a denial, why are these codes being denied? A lot of times it's because of these Ncci edits. And so even though we have so many different payers nowadays, CMS and their guidelines still kind of tend to be our baseline. They're our standard, and a lot of these private payers use that as kind of their baseline, and then they add to it as they see fit or what fits in with their policies. And so we really always kind of go to CMS and our local, our NCDs and our LCDs to see what some of these different edits are all about, right? And so here's some really great go-tos. You have your CMS Medical Learning Library, which is a great reference for anybody that is part of this lovely industry to go to and be able to have that information. So let's say you get a denial and you're not sure why. A lot of times you might get, that Ncci edit there. Really quick, let's do another quick poll. How many of you have access to something like a Supercoder or an Encoder Pro or some other type of online coding tool that you or your billing team uses to help kind of verify codes before they're submitted? Okay, so it looks like the majority of people don't have any type of access to these tools. It's something that, again, depending on your role, maybe it's not necessary, but it's definitely something to maybe think of. Most of these tools have kind of a cross-check where you can enter your coding into there, and then it'll kind of show you if there's any type of an Ncci edit where you might require a modifier there. So these are really great tools to help you. Again, references, and this MLN interactive correct coding tool is fantastic. It's free. It's something you can you can use it. It's wonderful. It's there for you, and it's free of charge, which we all like, right? Okay, performance measures, quality payment programs, MIPS, all that good fun stuff that came along a few years ago. Really quickly, performance measures are just there to help us kind of track what's going on within our clinics. And they're really there, again, this is a tracking thing. This is for contract negotiation. If we're paying attention to what these quality measures are, they are going to help us when we are negotiating contracts, especially with CMS, Medicaid, Health First Colorado. They are using these, and they are basing a lot of information that they're pulling off of your reports using these codes. I know that there is a performance measures cheat sheet that is put out. I'm not sure who is in charge of editing that, but they did mention that there will be some new edits being added to this cheat sheet. So if you don't have it, that's something really great to make sure when you start off the new year, the new school year, I should say, that you've got the new codes added to that. We basically use category 2 codes and CPT codes for these performance measures. So when you look at that cheat sheet, it kind of breaks it down, and you'll actually see what codes are being tracked within your systems. I believe you use Apex for that. And so it's all there for you, and it helps out, but it's also really good information for you all to be aware of, that these things are being tracked. Here's some areas of tracking that we are paying attention to. It looks like Maureen is in charge of editing, so thank you for doing that. That's awesome. Okay. Moving on to team conferences and nutrition therapy. As we were looking through one of the encounter forms that was given to us as one of the tools that clinics can use for their day-to-day, we noticed kind of a really big typo here, and we wanted to draw attention to it really quickly. Not sure how many people are using the oh gosh, that encounter form, but on team conferences, you see that patient family not present 30 minutes without provider is listed as a 99388 instead of a 99368. Unfortunately, we only had one clinic's reporting to go off of, so I really couldn't do any type of good analysis to see what our coding patterns were. But I wonder how many of you have caught this, have noticed it, and have changed it within your own clinics, or if you haven't noticed that very big typo, what's that? How is that affecting your reimbursement rates, right? What's that doing? And so we really want to make sure when we use things like quick coding tools, they're wonderful. They make our lives so much easier because we all know what our coding booklets look like and how big they are and how overpowering and consuming they can be, but when we see something like that, we wonder what that's doing and how is that affecting your reporting in the long run, or for how long, right? How long has that typo been there? Okay, Fqhcs. So I know we've got some Fqhcs on the line. I will be the first to admit I am not an expert on Fqhcs, but my good pal Ginger, who is on the chat, is. And so I'm going to go briefly run through some things here. We won't get super into it, but as I said, as we kind of go through, we will address Fqhcs versus non, as we kind of continue to talk about some of these more specific codes or billing. Making sure that we're using that qualifying clinician and a patient, defined as medical, a reimbursable Fqhc encounter is defined as a medically necessary visit between a qualified clinician and a patient. Making sure, in the research that I did, it looks like that Health First Colorado doesn't actually require the use of those Fqhc specific codes, and that you actually just report each individual code rather than that kind of main code that everything is encompassed within. So that's really great from a reporting standpoint because you're already using those individual codes as opposed to this one main code. So that really helps out to make sure that you are reporting these things. But this is just a few little must-knows about Fqhcs. And also the Fqhc resource. This website, it's this first link that you see up on top here. This has so much information on it. I mean, everything you could need, I think from an Fqhc standpoint in Colorado can be found right at this link. Really, really knowledgeable. It's got information on your billing manuals, just everything as far as where you can look for really great, solid information. And that's where a lot of our information as we continue to move forward has been found on this website. Okay, COVID-19 and the lovely things it has done for our telehealth and telemedicine. It has accelerated telehealth and telemedicine exponentially. We've been asking for it, patients have been asking for it, and we're so glad that it's finally here. And we're so glad that we have the opportunity to show how great it could be for our patients and for patient care. That now, you know, it's going to stick around. It's not going anywhere. So we really want to make sure that we're doing it correctly because we don't want to ruin anything, right? We don't want to move backwards, only forward. So these are a few really great resources within Colorado's website. Again, you've got these three links here at the bottom of this slide. Really, really wonderful to help you find out some of these information, these more specific information about the rules and regulations between telehealth and telemedicine within your clinics. The one really kind of good thing is, the hard thing, I guess, is every payer is going to be different. And so with that, we at RT Welter have a few coding and informational sheets that we'll be sharing in the chat at the break, which will be just in a few moments. We're going to go through, you can download those fact sheets right from that chat. So we'll go ahead and we'll be sharing those here when we do break. So feel free, download those, read those, share them with your team. They are full of information. And one of them actually has all of the various payers in Colorado, or at least a good portion of them, that has kind of their go-to websites and links that will help you as well to get to that right information or that needed information. Okay. So we've got some fun little test your knowledge, make sure everybody was paying attention. The first one we're going to ask is CPT codes describe procedure and evaluation and management services. True or false? Okay, so nice work, everybody. Looks like everyone got it. It's true, CPT codes do describe our procedures. Again, CPT codes, for the most part right now, most clinics, most payers are on a fee-for-service contract for reimbursement. So this is really what generates your reimbursement, is these codes. All right. Next, we have our productivity reports are used by payers to verify documentation, to verify that documentation supports code submission. Okay, looks like I tricked you up a couple of people on that one. It's false. Productivity reports are not used to verify documentation, but they are there to help support you in contract negotiation with your payers. It can help you to prove that, hey, look at all of the times that we report this code or are doing this service for our patients. We would like to negotiate with you to maybe increase that reimbursement rate for that code, or really to help you verify where your clinicians are at and what they're, you know, kind of, again, it's productivity. It's seeing what we're doing on a day-to-day basis. All right, and then the last one before the break. What additional services can be reported on the same day as a well child check? Okay, everybody got that one right. Nice work, everyone. All of the above, right? We can go ahead, we can report all of these throughout, in addition to a well child check. It's just depending on how we're coding it, right? How are we billing it, depending on that payer. Okay, everybody, we're a little bit ahead of schedule, but that's okay. We're gonna take a quick 10-minute break, stretch, maybe refill your coffee, do whatever you need to do, and then we'll be back at 10:25. Feel free to use this time, go back through the chat, maybe read some questions that some of the other attendees have been answering, maybe read some of the feedback that have been given by the RT Welter team as I've been talking, kind of elaborating on some of the things I've been saying. And then also we'll get those files uploaded here in the chat in just a moment. Okay, everybody, we're just going to give another moment for everybody to kind of get settled back in. Again, feel free to reference the chat. We do have those 2 telehealth and telemedicine fact sheets that have been added there. So feel free to take a look at that. Again, download it. If you're just on like a cell phone or a tablet and can't download that onto your device, we'll also include that in the handouts after the presentation with the slides and links to the recording and stuff as well. Okay, everyone, welcome back. So next we're going to dive into behavioral health. And again, I want to encourage everybody to use the chat. We also do have some time at the end where we'll open it up for, again, more Q&A. So we'll be able to address a few of the questions there as well. We are trying to monitor, but if questions get asked kind of in rapid succession, they might get missed. I do want to make sure that you are asking or adding the questions to the chat and posting that to everyone so that everyone can go back and actually see those responses as well as the questions asked. Okay, so for behavioral health coding, we want to make sure, again, everybody's on the same page. Here's some great resources. Obviously, CPT and Hcpccs is where we get all of our coding from. Also the DSM-5 for our diagnosis coding. And then the Medicare Benefit Policy Manual. Chapter 13 is going to be specific to our Fqhcs. RAIs, or the Regional Accountability Entities, are something new in Colorado, and this is really a really interesting, I guess, organization or newly founded region of the Denver or Colorado Health. These are really, again, these are advocacy, not advocacy, these are places that you can go to. Knowing your RAEs or your RAIs is going to help you with some of your questions that you may have. On the next slide, we'll get into a couple of really good links that you can go to, a couple of really great resources, but really they have 5 key responsibilities. They're coordinating, building, administering, monitoring, and improving patient care and the healthcare system in their areas. And it's really meant to kind of break it down. So instead of having one big state to go to or state office to go to, it's really kind of helping you out you know, because then they'll also know your area and what's pertinent to you. Somebody in, you know, somewhere like Summit County, Colorado is going to have different needs than one of the clinics in downtown Denver. Your communities are different. The big thing is that RAEs or RAEs replace the RCCOs and BHOs by combining their duties under one administrative umbrella. There's now 7 RAEs, and they're responsible for building the network of primary care providers in different geographic regions. They coordinate the care of Health First Colorado members and monitor data. So again, here's your data monitoring, here's your production reports, making sure that those production reports are relevant and do accurately reflect what it is your clinic is doing on a day-to-day basis. Regional accountable entities, or RAEs, they're here again, they're here for you. 3 big takeaways of this is that your RAEs are a new organization in the Health First Colorado and Colorado Medicaid program. They're responsible for coordinating members' care, ensuring they are connecting with primary and behavioral health care, and developing regional strategies to serve Health First Colorado members. While the aim is to eventually improve care, many changes are largely administrative and behind the scenes. And the RAEs are attempting to launch their programs without disrupting the services on, you know, the patient-facing services for members. And RAEs have common requirements and responsibilities, but they have latitude in how they can craft their regional strategies and relationships in healthcare providers. This is just a brief overview. Colorado Association of School-Based Healthcare will be doing a more in-depth webinar later on for RAEs, and so it is encouraged, if you do need to know more about this, please make sure that you register for that webinar. I don't have the exact date, but it will be something that you can definitely get a little bit more information on at that time. Okay, so behavioral health services. There's obviously some codes that are payable while others aren't, right? We already talked about just because a code exists doesn't mean it's going to be reimbursable or have any type of a reimbursement rate. But the one really big thing to keep in mind here is that there's a difference how we're obtaining this behavioral health, right? So just because one clinic is being paid for a service at $130 doesn't necessarily mean that the other clinic is going to get that same reimbursement rate. And this can be for many different things. This could be how they are set up in the system. Are they an Fqhc or are they non? What is their payer contract say? There was one question regarding reimbursement rates for behavioral health. And, you know, it's really dependent on your contracts and what those reimbursement rates are. So unfortunately, coding and reimbursement isn't a one-size-fits-all. Everyone is going to be different. Everybody is going to get reimbursed differently. And so it's really important that you know what your contract says and what your reimbursement rates are for certain things based on if you are Fqhc or a non. And then also a private payer versus Medicaid or Health First Colorado. We want to make sure that those things are always going to change how clinic is reimbursed for a certain code as well. This is also a great area for us to talk about your ability to use dummy codes. to track some enabling services, and making sure that you're using those EMRs and those systems to maybe add some of those things. One of the ways that you can start increasing payment is by showing that, hey, we do this for 90% of our patient population we're supplying this service to. That's a really great way to help with those contract negotiations. The other big thing that I want to mention here is that the EMRs, one of the hardest things when we're talking about a statewide program like school-based health clinics is that you have to have consistency within your EMRs and how you're reporting certain things or tracking certain things. So really kind of working together using the association to help you as an independent clinic or as a separate clinic find those exact same ways to track that maybe another clinic is, so that we get that consistency. So when we look at it, we know that that tracking code SCCC4 is used by all clinics to track this same thing, because then they can use their advocacy and their team to help make that tracking matter more when it comes to reimbursement. Enabling services are services already included in a per member per month payment for school-based health clinics. This is a really great graphic that I got from a tracking enabling services presentation that was done. It's not a Colorado company, but they did have some really great information as far as how to track and what is what's helpful, what they found. It is based out of Oregon, California, I believe. So definitely something that we're happy to share with you. There wasn't a link associated with it. I found it on Google, and once you clicked on it, it just downloaded the PDF right away. So it's not something I could link for everybody, but it is definitely something that we can include for you. If you'd like to read through it, it's something we can add again to the chat at the end of the presentation. It's really just going to have some really great information on the use of dummy codes and the use of procedure codes. The one really big thing that we want to make sure is that if you're using a dummy code, that it's not an actual real code, right? Because if you're reporting that to a private payer as well as CMS or Health First Colorado, it's really important that we make sure that we're not using a code that actually exists in our CPT. So using something that's maybe all letters, but sticking with that same format of 5 digits, whether those are letters or numbers. Okay, behavioral health. We're gonna kind of reference RAISE a little bit here because it is important. It does kind of fall in line. Anybody that did ask questions prior to today's presentation, these next few slides are really going to dive deep into some of the questions. So thank you for your patience as we all kind of got on the same page with some of the stuff we talked about previously. We're gonna start kind of getting into those now. So starting off, CPT codes 90839 and 90840 are psychotherapy for crisis encounters. Report code 90839 for 30 to 74 minutes and 90840 for each additional block or blocks of time up to 30 minutes and beyond the first 74. So what this means is that we're making sure that if you're spending, let's say 90 minutes with a patient, for these codes, we should be reporting 90839, 90840, okay? So we wanna make sure that we're getting that extra code because of our extra time spent with that patient. The one thing to keep in mind with that add-on code is that you have to hit that 16-minute mark in order to count that full 30 extra minutes. So that's why I said 90 minutes there. One of our questions, what needs to change when coding for behavioral health services outside of the 6 integrated behavioral visits at visit 7 and beyond? So this is a really great question. These links I have here, the second one is a really great fact sheet by colorado.gov that is specific to short-term BHS in primary care, right? So while the intent of the policy is to increase access to behavioral health services that can address a low acuity condition within 6 visits, the department understands that there may be times when a member requires additional services. In these instances, there are 2 options for accessing additional services. The first is a PCMP that has a licensed behavioral health clinician, who is contracted as part of a regional accountable entity, or array. Behavioral health network may submit claims to the RAE for reimbursement of additional visits beyond 6 during the state fiscal year. All additional visits must be provided in accordance with the RAE's utilization management policies and procedures. Okay, that comes right out of that second link listed on that slide, as well as a PCMP with a licensed behavioral health clinician that is not contracted as part of a RAE, as part of a RAE's behavioral health network, can work with their RAE to transition a member's care to another behavioral health provider. Any additional visits beyond 6 during a state fiscal year will be denied FFS reimbursement. Okay, so it's basically saying there's 2 ways. Either you make sure that your behavioral health clinician is part of that RAE, or you work with your RAE to get that patient transitioned over to a behavioral health clinician within their system. And again, that version, that second link, is from January 2019. That is the latest version that is available. There is nothing newer. And so that is put out by the Colorado Department of Healthcare Policy and Financing. These psychotherapy crisis codes are not part of SBHC. So again, that's these 90839 and 90840. However, crisis coding can be reported and are covered by your RAE under the capitated behavioral health benefit. The behavioral health codes chart, as seen, that we took directly off of page 13 from their provider handbook, we found this to be very helpful in our research. So again, this is all stuff that was taken, whether it was from the RAE's provider handbook or that short-term behavioral health fact sheet. Both of those are linked here, so definitely use those resources. They're very, very helpful. And they will kind of give you that guidance that you might be looking for. Also, the Uniform Service Code standards is there as well. Psychotherapy services. So identify the documented therapy. So if we're looking at this as an example, we have a patient brought a notebook filled with information she wanted the BHC to read about recent trauma. The BHC provided the psychoeducation. related to re-traumatization and trauma treatment course, provided cognitive behavioral treatment, facilitated processing of psychosocial stressors. Patient discussed her frustration at not feeling understood or that she can talk about recent assault. BHC encouraged her to discuss trauma when she is in WOT, window of tolerance, and she can process. Discussed and processed feelings and thoughts related to above. BHC read 1 page of notebook with patient and discussed her thoughts and feelings about sharing experience. So we see a start and an end time here. So we're at about 43 minutes for this encounter. And so the one really big thing to take away here is not only that we've got our documentation standards are being met, we also want to draw attention here to the Fqhcs and their need to submit 2 claims for something like this. One code would be the short-term behavioral health service using revenue code 900, and one would be the medical service using revenue code 529 for 2 encounter rate payments through Health First Colorado. So if you're seeing a patient and you're doing a medical service along with this great example of a psychotherapy service, you're gonna wanna make sure that you're submitting those 2 forms with your 2 different revenue codes. Okay, behavioral health screening and counseling services and SBHC. This is going to be, I'm sure, another pretty long slide, but we will answer a lot of questions, I hope. I'm going to first start off with a question that we had in regards to screening code 96127 and the use of that for pediatric patients. When we look at Health First Colorado's fee schedule, this doesn't have a minimum age to it. So from Health First Colorado's standpoint, they're not looking at an age range that this isn't allowable. However, from a behavioral health standpoint, this is kind of where we see an issue. And all of a sudden, your behavioral health clinicians maybe aren't getting reimbursed for this. So I'd like to kind of throw the question out, and everybody, if you could answer in the chat, please. Is anybody currently have a behavioral health clinician who is being reimbursed for this code? Okay, so we did have one person answer that they don't have a behaviorist using this code at all, and that's exactly right. So if you've got, I guess the big question is just if behaviorists are being reimbursed for this code, and this is something that we'll certainly spend some time and do some more research on for our next refresher in a few months. But definitely, if anybody has any feedback, I'm sure the person that asked that question might be watching that as well. So we did have a few questions, again, that we'll address here. The first one that I want to talk about is how to bill for both positive and negative PHQ-9, CRAFT, and GAD-7 screenings as distinct procedures, especially at a well child check, both for Medicaid and commercial. And so the one really big thing that we want to talk about here is that if you're doing multiple screenings, so normally we would use code 96127. The big takeaway here is if you look at this, the top right chart here, you see that 96127 has a practitioner service MUE value of 2. and an MUE adjunction indicator of 1. So what does that mean, right? So the really big takeaway here is your MUEs. CMS develops MUEs, or medically unlikely edits, to reduce the paid claim error rate for codes. An MUE for a HCPCS or CPT code is the maximum units of service that a provider would report under most circumstances for a single beneficiary on a single date of service. All HCPCS and CPT codes do not have MUEs, although CMS publishes most MUEs values on its website. Other MUE values are confidential and are for CMS and CMS contractor use only. There are 3 types of MUE tables available on the MUE site from CMS: practitioner, durable medical equipment, and also facility. MUEs are located in their files, and the table contains 4 columns. You have your code, you have your MUE value, and then you have the maximum unit of service a practitioner would report under most circumstances for a beneficiary on a single day. So when we look at this, our MUE claim line for date of service is the maximum number that you could have on a single line item. So let's say we did all 3 of those screenings on the same date as a well child check. Basically what this chart is telling us is that the maximum amount that you could put onto a single line item is going to be 2. So even though you performed 3 services, we're going to do 1 992 96127 with a line item quantity of 2, and then the second line item will be a 96127 with a modifier 59 and an additional 1 unit for that third screening test. Does that make sense to everybody?
Hi, this is Deborah. A quick question on that. My biller, they redo my coding sometime, and as I'm looking at what they're doing, they break it up and they put the 96127 is an individual line for each screening. You're saying if I have 3, then there should be 1 line that says 2 units and then 1 that says 1. Is it work against me if they're broken up to be 3 of 1s?
It doesn't necessarily count against you, and it could be dependent on the payer. Again, these are MUEs set forth by CMS, and so different payers are going to have different requirements. Some of them will just say enter each one as a separate line item. Others will say that you can actually just put a quantity there. And so it's not something that I think is counting against you at all, because it is still counting that we did these, let's say 3 screenings. So, but we're just counting it on separate line items is all.
So if we're counting them on separate line items, would 2 of the 3 need to have that 59 code modifier?
That's a great question. In the research I found, it said just that single line item would need that additional or that modifier 59. I would say if you're breaking it down on 3 separate line items, a 59 should be amended to anything after that first one.
Okay, thank you.
Okay. Our next question is in regards to SBHC services. And our question was, does the time requirement associated with SBHC, brief intervention codes 99408 and 99409, include the time to both administer and interpret the screening, as well as provide brief intervention? The answer here again is yes. And we're going to again look to our links. Basically, if we look at the wording, it says that let me find it. Sorry, everybody. That we want to make sure that the screening and brief intervention describes, screening and brief intervention techniques to clearly distinguish ancillary staff, including health educators, may perform SBHC services under the supervision of a credentialed provider. And it's basically saying these are time-based codes, therefore the documentation of the full procedure should be notated. It's there, it's definitely something that you find different wording for, but nothing that says that's not included. So if you're using your time codes, we just want to make sure that we are including that full time that it took for the staff to complete those. Okay, and that exact language could be found on page 7 of the link included, that second link at the bottom. Can non-licensed providers, such as health educators, deliver SBHC under the supervision of a licensed provider if they meet the training requirements outlined on page 5 of the Medicaid SBHC billing manual? So again, we're going to use that same link as we referenced just that previous question. And the supervision of the non-licensed professional is within the legal scope of practice that licensed of practice for that licensed provider. Pardon me, everybody. And again, the answer is yes. Non-licensed staff, like health educators, with appropriate supervision or plan of care by the supervising licensed provider, can still deliver these services. One kind of disclaimer on that too would be to make sure that documentation of training is on file, that you have that. It's just, you know, always best to have it, so if there ever is a question or it comes back, we make sure that we do have that information so that if anything is ever needed, you can support that staff member did have the appropriate training. Okay, and our last question that will go along with this slide is, when is modifier 59 required to bill for SBHC services? Health First Colorado's policy is to allow SBHC codes to be billed on the same day as other evaluation and management services. Therefore, there is no need to amend a modifier here. However, this is just Health First Colorado, and if you're receiving denials, one of the reasons could be your Ncci Edits. And so definitely making sure, check your NCDs as well as your MUEs for these, and reach out to your payers. You know, if it's a private payer that you're receiving denials on these for, reach out to them. Make sure that it's maybe not something that's part of the contract, or it's just not being reimbursed for some reason. It's really hard to generalize and say this is exactly why, but here's a good place for everybody to start. Okay, SBHC and reporting and documentation. So one of the really big questions that I wanted to address first was, will SBHC services be reimbursed if associated with an annual well child exam? And the one really fascinating thing I found when I was researching these codes in Health First Colorado's fee schedule was that there is a minimum age requirement for these codes, and that minimum age is 12. So if you're reporting this with a code, or pardon me, with a well child or preventive medicine code 99383 or 99393, which would be up to age 11, that could be one reason why you are either not getting paid or it's being denied. That was really interesting. Always make sure we're paying attention to things like that. It's something that it's really easy to kind of forget about and maybe skim over, but that was something I found really fascinating, especially when you think about when kids maybe try smoking for the first time. I feel like a lot of people that I have encountered in my lifetime, you know, if they are smokers, they maybe tried their first cigarette before the age of 12. And so this is something that maybe, you know, as a collective, you know, advocacy could get out there and help change, because that's the perfect time to try and get kids to change and not have those habits as they get older. I feel like by the time they get to maybe age 12, if they started at 10 or 11, it might be a little too late to already grab them and bring them back and get them to stop that habit. The next question is, can H0049 be reimbursed if only the pre-screener questions and CAR questions are asked and not the full 6-question craft? Unfortunately, the answer is no. And the reason for that is that there's 3 requirements that must be met in order to report code H0049. The first is that we have to have a positive pre-screen, right? There's something that makes us keep moving forward. And then the full screen is negative. And then the brief intervention or referral for treatment is not necessary. So this code is basically paying you for the time it took to go through these steps, but now all of a sudden we don't need to move forward with that intervention. I feel like this could be a discussion point, and if anybody would like to jump in and ask more questions, we certainly can do that. Or, you know, if you want to hold off or you want to enter it in the chat. But I feel like this is a good discussion point. If anybody would like to jump in here, feel free. If not, that's okay. But it is a really great question that I feel like maybe there's a lot of uncertainty and gray area with this code. Nobody? Okay, we'll keep moving. And that's okay, because the next question kind of piggybacks right to this. And then the next question is it permissible to bill code H0049 for a positive craft screen with brief intervention less than 15 minutes? And again, we're going to draw our attention back to that orange box, and the answer is no. And the answer is no, because a brief intervention or referral for treatment is not necessary, because that positive craft screening also didn't happen. So right there with that question, we're hitting 2 of the requirements aren't being met. There's a negative full screen, and there's no need for intervention or referral. Okay, and finally, is tobacco dependence necessary before you can bill for tobacco cessation? The answer here is no. And just a little bit of background here. SBHC services may involve using tools to assess a client's readiness for change, or their barriers to change, or advising in changing that behavior, providing specific suggestions, and arranging for services and follow-up. The key here is that the behavior change related to substance use. And you see that underlined. We want to make sure that it's not a requirement that they have to have this dependence. We're trying to curb that change. We're trying to help them before it gets to that dependent state, right? We want to get kids before they're become, you know, pack-a-day smokers for 15 years. It's a lot easier to change that behavior now and try and get them to change. So that's really what this is about. It's about prevention. And the link at the bottom of this slide is a file document that RT Welter put together last year in regards to SBHC, and that's where a lot of this information came from. It's a great kind of go-to resource for all things SBHC, especially in the school-based health clinic place of service. Okay, so more on SBHC and tobacco cessation. So number one, can 99408 and 99409 be used for SBHC without the need for an additional CPT code? Absolutely. According to national coding guidelines, SBHC codes can be the primary or only code reported for the data service. So if somebody's just coming in because, you know, we're dealing with a substance use, we can absolutely just have that conversation, and then they can go on with their day. The link at the bottom is also something that there's nothing, again, coding is very general, and sometimes we just have to go with what we have, but there's nothing that says that they can't be. So because we don't have anything that says, you know, absolutely not, we know that they can be. And so sometimes that can be a little hard when we're reading through some of these really legal sounding documents to kind of pull that out. But you should be able to bill those just by themselves without a problem. But again, it could always go back to your contract language, specific payers, all that kind of stuff. So definitely, if there's one payer that you're always seeing an issue with, maybe reaching out to them, looking at their website or their guidance on certain codes specifically, and also verifying with what your NPIs are. Okay, question number 2, how do you code bill for a second brief intervention done on a different day, but within the same 12 months? And we kind of loved this question. Again, this is an area I would love for some interactive discussion if anybody is feeling up to it, because my first question went after I read it was, well, why aren't you now counseling on this, on what the intervention would have been, or the substance use? You know, I think of codes 99401 through 99404, where it's risk factor reduction, and maybe using those codes as opposed to a second brief intervention. I kind of hear the word intervention and I think that's that first, we have a problem, let's address it. And now that that problem has been established, we're no longer it's no longer an intervention, now it's counseling. So if anybody has maybe some thoughts on that, or, you know, I'd love to discuss and maybe hear some feedback.
Hey, Laura, this is Ginger.
Yeah.
I just wanted to bring your attention to a clarifying question that McKenna had asked. It looks like in the chat on what you were just talking about. Can you help clarify some of her confusion about the SBHC code?
Okay. Sorry, I'm just reading through the question. Okay, so McKenna, you asked, sorry, I am just so confused. So this is not considered an SBHC code, or is it? And if it is billed during well child, they must be 12 and older. Also, we give Just Health screeners to all well child 11 and older, which is a smart screener. Okay, so, right. So when you're talking about using the use of code 96127, and let me go back. So 96127 does not have any type of age requirement to it, right? So that is your screener questions. Those are your craft, your PHQs, all of those things, right? Those are there's questions you're screening for. However, when we move into the SBHC codes, this is where we see the minimum age requirement. So if we're trying to do a 994 99408 or a 99409 or an H0049, there is a minimum age requirement. So all of a sudden, if you screen and you realize that now we're moving into intervention and treatment, so we would report a 99408. Normally, if the child is 11, this will cause these codes to either be denied when reported with a well child check after, before the age of 12, or it could lead to a zero reimbursement. I'm not sure if you all are all seeing that or not, but I did recognize that on the fee schedule when researching these codes, that there's a minimum age requirement. And I'm not sure if anybody, it wasn't a question other than, people asking if they could report an SBHC code with a well child exam. And the answer is yes, you can, but if you're reporting it for a well child that is before the age of 12, you could be seeing a denial or a zero reimbursement, and this minimum age could be the reason why.
Okay. Sorry, that makes a lot of sense. Thank you for clarifying. I have no clue. Like, I was kind of put into this position a year ago and have been flying by the seat of my pants ever since. And so I want to make sure I'm getting everything correct. So the 99408 and 409, those are the SBHC codes along with the H0049.
Correct.
Okay. All right. I got it. Thank you.
Okay. Perfect. Yeah. No, I'm glad that I was able to clarify. Sometimes I talk or I have it written down and I'm saying it and, I could completely talk in circles sometimes. So thank you for asking that clarifying question. I'm glad I was able to help out with that.
Hey, Laura, it's Ginger. I have one more clarifying question I'd love for you to go over. And you've already talked about it, I believe, briefly on the previous slide.
Okay.
About the certification education requirements for the clinical staff that's providing those services under clinician supervision. Can you just comment on that again, just to clarify those details?
Absolutely. So as any good legal document that we read for guidance, sometimes it kind of talks in circles. And so if you look at the box to the left, which is kind of that gray color, it says clinical guidance for procedure codes 99408 and 99409. The very bottom paragraph states ancillary staff, including health educators, may perform SBHC services under the supervision of a credentialed provider. The service should relate to a plan of care and will require billing under the supervising physician. So basically this means it's the ancillary staff, health educator who's doing the service, but we're going to bill it under the provider or the clinician, the certified provider's number. Okay, so what it's saying is it's not the clinician that's doing it, but they are overseeing this health educator, and it's part of a plan that I, as a certified provider, have come up with. So I sit down with the patient, I've met the patient, we came up with this plan. Now my health educator is going to use these SBHC services and are going to be the actual person providing that SBHC service to the patient. I am not in the room, but I am supervising. I am signing off on their documentation. As a clinician, I'm saying I'm aware of what they're doing and I agree with their assessments, with their notes, and that. Does that make sense? Does that help clarify? No? Did I confuse you more? Okay, perfect. Okay. Great. I love this. This is a great spot for all of this. So, okay, I think we had kind of addressed that second question. And again, if you have questions, if you'd like to discuss that, I'm really curious as to why, maybe we would do a second intervention within a year period. So, that's something that's very interesting to me, but we can certainly kind of scrap that. But again, kind of short answer would be, potentially using codes 99401 through 404 for that risk factor reduction. Or even maybe there's a different code based on what type of counseling we're doing there. We're going to move on to question 3, which is, can you be reimbursed for both tobacco cessation and SBHC services on the same day? Absolutely. But how is it being documented, right? It's absolutely, but, making sure, because both of these are time-based codes, that the documentation is very clear about the time spent in each of those different services, and that they're separately identifiable. Remember that Fqhc's SBHC services are not separately reimbursable, but they do require that you report those codes. So making sure that just because you're not getting paid for it, you're still reporting them. Very, very important. Next question, is tobacco dependence necessary? I think we kind of addressed that. And again, it's not. Definitely even, anything, we want to talk about prevention, and we want to talk about helping before dependence happens. You can look into the DSM-5, and there's really great information about use, abuse, and dependence. Also in that SBHC manual that I have the link to on that previous slide, there's also another really great use, abuse, and dependence kind of chart that you can look at for you coders and billers out there who aren't sure what to bill for, if it's documented as both or all three. And finally, do Fqhcs receive additional reimbursement for tobacco cessation counseling, or is it bundled into the encounter rate? Again, kind of goes back to one of the previous codes. This is part of the encounter rate. However, we weren't able to find any exact documentation from the state of Colorado, Health First Colorado, that specifically listed out what codes are included in that overall encounter rate. And so what we found was that 99406 and 99407 were included in the national Fqhc. And so if anybody has a reference, there was nothing we could find that exactly showed all of those different codes broken down. And I suspect it's because Colorado doesn't maybe want you to know, because they do have you report all of your codes, and then you just kind of end up with maybe just one reimbursement code. And I'm not sure if you're ever told exactly what is included there. So if anybody has any input there, that's what we were able to find on our end without having a more specific, this is for this clinic. Again, we're going off of general guidelines.
Hey, Laura, this is Ginger. I just wanted to piggyback on your great information on that, just only specifically to the Fqhc environment. But we see under the Medicare policy that they do cover for these codes as a qualifying visit solely by themselves. However, we have to keep in mind what that qualifying visit encounter really means, and that's that face-to-face encounter with the medical professional. So then we get away from the medical staff doing that if you're only billing for tobacco cessation in an FQ. Now that is CMS Medicare rules with our qualifying visit. And one thing I wanted to find out that Laura was explaining was whether or not that was true to Fqhc Medicaid, and if you guys could provide those services by the clinician and get reimbursed for those at your encounter rate. And so that was something I'd love to verify. I don't know if anyone from an FQ knows the answer to that, but that is something that we will continue to dive into and research to try to answer that question a little more clearly. So if you were to provide a cessation service without anything else, could we report that as a qualifying visit? So more to come on that.
Perfect. Thank you, Ginger. Anybody? Feel free to use the chat too if you'd prefer that as opposed to talking. We'll continue to move on. HBAI visits and services, again, referring to the encounter form that kind of has a list of all of your go-to codes. These have all been deleted as of 2020. And it's really great because now we actually are getting paid for some additional time. So if you look just below, you'll see all of the new codes. So you see they've taken the 6 initial codes and kind of broken those down a little bit more. So instead of just getting a one flat rate, regardless of time, now we're being reimbursed for our initial 30, as well as add-on codes for each additional 15 minutes, which is really, really great. You know, it will allow you to start kind of seeing a little bit more coming back from a reimbursement standpoint for that time spent. And then just a really great reminder of health behavioral assessment and intervention definitions. This comes directly out of CPT, and I use the AMA version. So this is right out of their book. One really big thing to keep in mind is that our add-on codes, making sure that we're not reporting those for any less than 16 minutes. So let's say we see a patient for, let's say 44 minutes. We're not going to be able to get that additional code. And again, if we look to our CPT books, we get that parenthetical guidance that says, do not use codes 96159, 96165, 96168, or 96171 for less than 16 minutes of service. So they're really kind of, they're gonna be sticklers on this. So everybody watch out. You know, making sure that we're not being too lax with our timing there. These can be reported with E&M services. However, they cannot be reported on the same date of service as code block 99401 through 99412, which is our counseling risk factor reduction and behavior change intervention services by the same provider. So that same provider can't kind of piggyback the two. Okay, I'm going to go ahead. I'm not going to read this code out or this description out, but I want to see, I didn't do a poll for this one, but let's just see if we could get some people in the chat to, based on the scenario we have here, if anybody can put in what code they think it would be. Okay, so looking back at our chart here, we see that this particular encounter was coded or was documented at 31 minutes. So we would use a code 96158 for this encounter if this was all that was documented. Okay, so we have some more quick test your knowledge that we'll go ahead and do really quick. First, codes 99408 and 99409 can be reported without an additional CPT or HCPCS code. Okay, excellent. It is true. It can be the only reason or the only code reported for a date of service. Next, which is not a requirement to report H0049. We have a negative full craft screening. Patient is a Medicaid enrollee, positive CAR pre-screening, or there's a need for brief intervention or referral to treatment. Okay, kind of tricked you guys with this one. It's D. So it is the need for brief intervention or referral to treatment. Remember, with H0049, we have to have a positive pre-screen, a negative full craft screening, and there is no need for referral or intervention. Okay, and the time requirement associated with SBHC codes 99408 and 99409 include the time to both administer and interpret the screening, as well as provide brief intervention. Okay, looks like everybody was on board with that one. That is true. We do not need any other procedural codes to be reported on that same date of service. Okay, everybody, so for the last little bit, we're gonna briefly run through some diagnosis coding. We're not gonna spend a whole lot of time here because I would like to allow for adequate time for question and answers as we kind of finish up here. So we're going to breeze through. Feel free, again, use the chat, ask questions, jump on, unmute yourself, and stop me, and we'll certainly address whatever questions you might have through this part as we kind of jump right through. So diagnosis, coding, and reporting. Obviously, we use our ICD-10 CM book. This is our Bible as far as diagnosis coding, and it contains, I think at last count, 70,000, something like that, codes. When we look at that, it can be overwhelming to any of us. We have provided, as part of the handouts, our RT Welter diagnosis coding booklet. This is something we've put together, and we base it on specialties as well as maybe problem areas like diabetes. And it lists all of your codes that are going to be most frequently used within either your specialty, like a school-based health center, or based on your patient population. So take a look at that. It's really great quick reference guide for you. It is in a PDF format, so you can easily go in, do your quick Control F and search for what you're looking for. And it's really easy, nice, instead of lugging that big book around with you all the time. Okay, top 5 diagnosis coding guidelines. Document and report all conditions that require or affect care. This is a big part of it. We want to make sure that if we're seeing a patient who has a chronic condition, that always kind of is in the back of our head. It's affecting how we're going to treat this patient. We want to make sure that we are also reporting that, because it does affect care. It is, in the grand scheme of things, it is important, and we want to make sure that we are paying attention to that. That also comes into play a lot once we start talking about risk adjustment, which we'll get into in a few slides, as well as reimbursement based on patient presentation, diagnosis coding, those types of things. Your chapter as part of the RT Welter diagnosis coding booklet, we do have some guidelines added to that page 2 of that. Feel free to use that, highlight it. It's really great to have handy. Also, you can download PDF versions of the ICD-10 guidelines right off of the CDC's website, which is really, really great, because you can, again, searchable PDF, get to what you need really quickly. It's a really great tool, especially if you're kind of in a newer specialty, so you're seeing some of those diagnosis codes for the first time, until you kind of get familiar with those chapter guidelines, chapter specific guidelines, I should say. ICD-10 is copyrighted by the World Health Organization. They own it, they publish the classification, and they are the ones who authorize development of ICD-10 for use by the United States. ICD-10 came out back in 2015, and so most of us are familiar with it. We've kind of thankfully put ICD-10-9 behind us, and just in time for them to start talking about ICD-10-11 or ICD-11, not 10. And we'll see when that happens. But things are always evolving, as we saw this year and just a few months ago. That need for new codes to be put out immediately so that we could start tracking and we could start keeping track of these cases of COVID that we've seen. So always keeping up to date with ICD-10 definitely will be beneficial, but making sure you know those guidelines, knowing your order for reporting certain diagnosis coding and when certain codes are reported first. Common EMR diagnosis description errors. We see this so very frequently, and as coders, as billers, as administrators, it's really important that we recognize that this is an area of concern. A lot of times we have a drop-down menu where our clinicians, our providers are searching for a term and they're clicking on the first one, or they're reading through that description and they're picking that first one that sounds right to them. Well, what's put into the EMR isn't always what the code actually means. And so a lot of times we see unspecified codes being given names that aren't really for it, but it's what you would code for. So it's really hard. Sometimes you just kind of get a little boggled there. So especially if you're moving towards a risk adjustment model, if you're starting to see some of your payers wanting to start to do some type of a reimbursement with diagnosis coding, it's very important that we make sure our EMR systems are correct and that they are correctly reporting diagnosis codes, because it can make a really big difference. And I'll show you that in a few slides. Risk adjustment and HCCs. Again, this is kind of the reimbursement of the future. These are things that we're going to start seeing more frequently through our various payment models. And we're basically looking at these ICD-10 codes. We're looking at patient presentation here. This is not a new thing. Since about 2003, the OIG has been working towards accuracy of diagnosis coding and the payments and how it affects that reimbursement. This also improves the quality of the record, right? If we're seeing a patient that has type 2 diabetes and we're coding them as an E11.9, which is without complications, but really they're on insulin. That's not without complications. We want to make sure that we're coding that correctly. Or we've got a patient with type 1 diabetes, but they've been coded to a type 2 diabetes code. We want to make sure that those things are recognized. It does affect our documentation. And then really briefly, risk adjustment is just a method of analyzing and using diagnosis coding for financial forecasting. It's becoming more popular with payers because of the forecasting, being able to look at a patient in 2017 and help to better predict what their overall patient cost will be over their span of care, and what that diagnosis costs. Because that's what insurance companies are worried about, right? Is how much is this going to cost them? So we really want to make sure that we're adequately reporting so that we're also getting reimbursed properly for that patient. This also brings in the Affordable Care Act and what that did for risk adjustment, and making sure that part of the aim of the Affordable Care Act was to eliminate incentives for health insurance plans to avoid people with pre-existing conditions, right? They tried, that was one of the biggest things, was that health insurers were no longer able to deny coverage to somebody because of that pre-existing condition. So this kind of all works into that as well. Here's just 4 really good takeaways for risk adjustment and understanding it, understanding what it does, and the HCCs. Okay, so again, we're going to talk about analyzing your data and the frequency of coding. Again, we're going to look at these unspecified codes, or kind of these codes that we want to focus on. This is a code frequency for a clinic. It's not a pediatric clinic, as you could probably tell from some of the codes that are listed. But we want to make sure that you are recognizing what this means. And if you're pulling this report and you're doing that critical thinking piece and you're saying, well, gosh, my #1 most reported diagnosis code is, let's say it's essential hypertension, and you're like, that's not right. why isn't it right? Let's look at it. Let's think about all of these things that we just talked about and why those codes might be off. And so this is a really good, again, these reports are here to help you to make sure that what's being reported on the back end that maybe you're not seeing, because sometimes those E&M visits are being coded specifically by our clinicians. So a lot of times we might not even realize that they're coding this code every single visit, and it's not accurate. It's not a correct code. They shouldn't be reporting it. So really pulling these reports and making sure that we're aware of what's being reported to our payers, because they're paying attention to this too, and they're keeping track of it on their end. Really quickly, just a little bit about major depressive disorders. PTSD is another good thing to kind of talk about here. This is a snapshot, again, out of our diagnosis coding booklet. We really want to focus on really the single versus the recurrent. This is a very big difference here. We want to make sure that we are paying attention to our documentation and that our clinicians are appropriately documenting it, because if it's not documented correctly, we can't code it correctly. So really making sure that we know the difference between the single episode, the recurrent, that mild, moderate, and we're getting that correct feedback and that those are being correctly coded. Here's a great example of risk adjustment and HCC values. This will give you an example of what that means from a reimbursement standpoint. So if we're looking at this example and we have a major depressive disorder, single episode, unspecified. So the documentation says major depressive disorder, and that's it. So we're gonna go to an unspecified code because we can only code to the greatest specificity that we as coders know. So we use this unspecified code. It's got a $0 risk adjustment or a 0 HCC. So it's not going to add any in the grand scheme of things. It's about $700 per year, right? But then if we actually go in and we've gotten more specificity in our documentation and we're able to code this to now it's a single moderate, but this patient also has alcohol dependency in remission. Now all of a sudden we've over doubled the reimbursement rate for this patient in a single year. So we'll get more into risk adjustment and kind of break it down. We could give full 2-hour-long presentations on risk adjustment, but just to kind of keep it in the back of your head, specificity matters. You know, it's no longer just about use this code because it pays. We want to make sure that we are being as specific as possible with our diagnosis coding. Again, just another really great visual of specificity versus unspecified, making sure that we are paying attention to these and what they can do for our coding patterns. Another great slide just for a couple of take homes, you know, kind of flag it. If you take nothing else away from everything that I talked about with diagnosis coding, here's 4 quick takeaways for you. And then here again is another visual. This is from a pediatric clinic, and you know, reports matter, reporting matters. And so when we look at it, we can look at it and we can say, well, it looks like based on the screenshot that we have, encounter for immunizations is their most reported diagnosis code, with encounter for routine child health examination with abnormal findings being the second most. And so we can kind of look at this, and again, we can do some of that critical thinking, but also when you're pulling reports, make sure you can actually sort your data. This is something that, this was the most sorting that I could do with this report based on the report itself. And sometimes that can be a major barrier for you as administrators and coders and billers is that you can't, the information you're given, you can't adequately analyze it. And so working with the EMR company or your technical team to try and find those good reports that you can run so you can quickly find this information that you need to properly analyze what's going on. Really quickly, going to go over Z codes. Again, this is very important in health, school-based health centers, in community centers. When we talk about Z codes, these are factors that influence health status and contact with health services. So this is where you're going to see a lot of those kind of these codes that haven't been given a lot of attention in the past because people think that they don't pay on things. So again, we're talking about what is it that these codes are giving us. And really the purpose of Z codes is they tell the story of an encounter when a patient presents for something other than evaluation management of a disease process. They indicate that a patient is seen for the sole purpose of a special therapy, such as radiation or chemotherapy, and they include facts about the patient's history, family history, or other statuses that affect their care or affect treatment choices. So this is really important. This is where you see for older patients where if they are a do not resuscitate status, those things are very important. We want to make sure that we're carrying those through on the documentation. Again, guidelines can be downloaded directly from the CDC's website, and the Chapter 21 is going to be your chapter specific to your Z codes. Your Chapter 21, here are your blocks. So everybody, if you're not fully aware, when we talk about ICD-10 codes, we have codes that are 3 to 7 digits. Our 3-character codes are considered categories. Our 4 and 5 and past that are considered subcategories. So when we look at this, we're looking at our blocks. So let's look at code Z40 through Z53, encounters for other specific care. Those are our categories. And so if we look at this, the really big one that I'd like to kind of draw your attention to is Z55 through Z65. These are our social determinants of health codes. These are those things that are outside forces that affect care or affect treatment because perhaps there's homelessness, perhaps there's lack of food stability, things like that that you might be seeing in your clinics. We want to make sure that we're reporting those. Those are really important for your advocacy and for your tracking purposes. It's going to tell a story of your patient population and what's going on with those patients. Icd-10 and Wellness. Again, these are just kind of your go-to codes. Somebody comes in, they're feeling great. You've got a Z code. It's an annual wellness without abnormal findings or with abnormal findings. The big thing I'd like to let you know about with these codes is to make sure that it is without abnormal findings if it is not found in the exam or by the clinician. If a patient comes in and says, I'm feeling great, but I've had this cough the past few weeks, I think it might be allergies, that's going to be without abnormal findings, right? But if a patient comes in and they sit down for the exam, the provider listens to their lungs and hears a little bit of wheezing, that's going to be with abnormal findings. We need to figure out what that wheezing is. Is this something that is new? Does the patient know about it? Are they aware of it? What's going on here? This is something new to the provider. It's something that we weren't expecting. ICD-10 annual preventive services with or without abnormal service or abnormal findings. Again, that just kind of a good example. And then here is conditions affecting care. And this is where we're going to kind of start talking about our morbid obesity, making sure that we have those codes properly assigned, including our BMIs when available. And it should always be available, right? And then that avoiding unspecified versus use of cigarettes and vaping is probably a big one for a lot of your clinics. Again, conditions that affect care. Screening and diagnostic coding. Again, these are some of your Z codes. The use of rule out versus confirmed, signs and symptoms versus confirmed diagnoses. Sorry guys, I'm trying to go through these really quick so we have time for questions. Common ICD-10 coding errors. So again, social determinants of health. This is going to be a great slide. If you print out one slide of this whole presentation, I strongly suggest it's slide 71. These are going to have a lot of really great information for you, and it's a good quick reference. Pregnancy complications, not sure how much of this you see, but this is definitely an area to be aware of. And let's do a couple of quick questions. I just have 2 more left, and then we'll get to some question and answers. ICD-10 codes describe signs, symptoms, and confirmed diagnoses. True or false? Okay, everybody got that one right? Nice work. It's an easy one, kind of a go-to. Next question we have here is going to be ICD-10 Chapter 21 or Z codes are used for which reason below? They tell the story of an encounter when a patient presents for something other than evaluation and management of a disease process. Indicate that a patient is seen for the sole purpose of a special therapy, such as radiation or chemotherapy. Include facts about patient's history, family history, or other status that may affect care or treatment choices, or D, all of the above. Okay, looks like the majority of people got that right. It's D, all of the above. All of these things can be found in your Z codes, chapter 21. So make sure that you familiarize yourself. Again, a couple slides ago, it kind of broke down the Z codes and all the different categories or blocks of categories that all kind of go together. So definitely something to keep close by. Again, just a couple of quick little take homes when it comes to ICD-10. And, you know, again, if you take home only 3 things from that, maybe some of these will be them. Finally, the post-training surveys. Christina did say this will be sent out after the presentation, along with the link for the recording, things, some other of the PDFs that we'll have. Please fill these out, get these back to us. I would really appreciate any feedback you have for me as a trainer. It does help me out to grow and improve as well. Also, the last question on that survey is to give us a couple of dates that might work well for you to be able to join us for that refresher course. We want to make sure we can get as many of you back for that. So definitely give us an idea if there's a certain day of the week that works best, anything like that, so that we can make sure we can try and get everybody involved. All right, finally, any questions, feel free, again, use that chat box. Feel free to unmute yourself. If you have anything you'd like clarified, please, now is a great time to do that.
This is Deborah. I have a quick question. It'll take me forever to type it. Time. If we're billing on time and we have, you know, like a 99213 based on time, but then we also did expert services. Is it legit that I know we have to break out those time codes and specify times for each part, but did we have like kind of 3 time statements, one for the total time for the visit, and then break it down, this much time was spent on expert specific, and then this much time was spent on discussing the other counseling? Does that cover it?
Yes, that will absolutely cover it. What I have seen is you have an overall time statement, right? So total encounter time was 60 minutes. Of that, greater than 50% of that time was spent in counseling and coordination of care of X, Y, and Z. And then maybe under their tobacco usage, there's a statement that says, you know, 6 minutes of tobacco cessation, you know, also provided, you know, along with brochures on X, Y, and Z about tobacco use, and then this time not included in overall time or something like that. Because even if you don't have that little blurb about not included in overall time, we can still take that 5 to 10 minutes of specific cessation time, pull that out of the overall 60 minutes, and we still have that, right? But as long as it's documented clearly, you will absolutely be able to code for both of those.
Great, thanks.
We've got about 4 more minutes before our time is up, but I'm happy to stay on a little longer if needed. If there's any other questions we can clarify. Aubrey, I thought you said there was maybe a question or two in the chat that wasn't addressed.
I think you might have answered them, but I think they were from Jeanette and from Deborah. So Jeanette and Deborah, if you had a question that you asked earlier that didn't get answered, you can feel free to ask that now.
This is Jeanette, and I did get my question answered. However, I did have an additional one, and I just posted it, but I'm curious about if billers and our clinics are using the Colorado Coding Standards Manual. And the question I have is whether there's a section there about the staff who can bill certain ICD-10 codes. And I'm just not certain, so if people are using that and how they're using that.
That's a great question, Jeanette. I am not sure on that. I'm happy to research that and either get back to you directly or we can address it in the follow-up refresher webinar. It's definitely something that is very interesting. If there's anybody that's still on that maybe has some feedback on that, please feel free to jump in. I don't know the answer, but I'm happy to look into it for you.
Thank you.
You know, and I want to just piggyback on that where you're asking about certain ICD-10 codes. Are there certain services also? I'm trying to pull that document up, but it is going to take a little bit to load.
So it kind of breaks it down. So it describes the CPT code with a description, and then it'll talk about the minimum requirements and any notes. It also indicates like what places services are payable. I believe it's payable. And that was kind of my question is, you know, I know that we can have a place of service and there's a check mark box And I believe it's to indicate that it's payable if it's provided in that place of service.
Well, what I'd like to do is study this document that you provided and then dive into that question a little bit more detail and see if we can make sense of the way that the document's written up. So we might need to follow back around with that.
Great. Any other questions? Anything else that we maybe had missed in the chat?
I have a quick question on integrated, and this is kind of looking forward. We are integrated. I'm family nurse practitioner right now, and I have a licensed counselor usually in the clinic. And so I understand some of those differences, but in the next few months, I plan to have my Psych NP certification as well. Is there going to be any interference with that? Like, I know in some integrated clinics, they'll bill for a medical visit and therapy, same day, same visit. I've been trying to find any cheat sheets or something somewhere to kind of clear up what's allowed, what's not allowed, being integrated with medical and psych. Any heads up on a spot to look for some of those things?
Laura, I'm happy to comment on that.
Oh, okay.
I'm sorry.
No, you're fine.
This is Ginger. And one of the very first things that I think of is the Ames website. Have you heard of Ames at the University of Washington?
I've heard of it, but I've only heard of it in the context of they had a tool that we could track positive depression scores and stuff. That's all I'd heard.
That's where they actually initiated the setup of the collaborative care model program, was at the University of Washington, and the Ames Center is the one that set that up, and they're a very excellent resource for a lot of that collaborative integration that you'll probably be doing with your new credentials. So that might be a good place to start. I'm so glad that you shared this. What I plan on doing at our follow-up webinar is to provide some coding tools for the clinicians of the practice, which would help with E&M services, as well as a behavioral health coding tool that will have the health and behavior assessments, psychotherapy, and some of those integration and collaborative codes as well for psych. So we can provide some more information at that time, but I think that maybe going to the Ames website would give you a great start with that, and it's AIMS.
Okay, I'll do that. Thank you so much.
You're welcome.
And so we're just a little past time. I know that your time is important and you have things to get to. Thank you all so very much for joining us today. If you have any additional questions, again, we can certainly stay on. I did want to go ahead and share this slide really quickly before people jump off, since there are some really good links here. These are a lot of the places that we went to for some of our information. And so just making sure that everybody does have access to that. And again, the slides will be available and sent out to everybody who registered from the association team members. So, but thank you all so much for joining us. It was really a pleasure to have all of you, and we hope to see you back in a few months for a refresher.